Lateral Epicondylalgia by Katie Wagian and Lex Potter. What is lateral epicondylalgia? It is considered tennis elbow. It's a degenerative tendinopathy characterized by pain at the lateral epicondyle aggravated by resisted muscle contraction of the extensor carpi radialis brevis. It is also considered pain over the lateral humeral epicondyle, which manifests during activities involving the hand in gripping or manipulating an object. The prevalence and incidence. In the broad community, 3% of the general population have this condition. That is 5 to 7 in every 1,000 general medical practitioner visits. At-risk populations include tennis players, fish processing workers, and those working in industries with repetitive manual tasks. It is considered as high as 15%. The incidence is the same in men and women, and symptoms are more commonly seen in the dominant arm. The diagnosis. First, you start off with a history and physical exam. Typically, there's a history of repetitive activity. Symptoms can be insidious. Imaging can be performed to confirm the diagnosis. Radiographs show calcifications within extensor mass origin or intra-articular pathology. An MRI shows thickening of the extensor origin seen in 90% of symptomatic patients. The gold standard is when a patient comes in complaining of pain over the lateral aspect of the elbow. Here is a test to diagnose lateral
epicondylalgia. Hi, my name is Elena Polakis.
And I'm Tiffany Woods.
And today we're going to be explaining the Cosen's test of the elbow.
This is Cosen's test. The purpose of this test is to determine if a patient has musculotendinous pathology along the common wrist extensor tendon attaching at the lateral epicondyle of the elbow. When overused, this relatively avascular muscular attachment can become damaged or inflamed. This test is commonly used to rule in or rule out lateral epicondylalgia or lateral epicondylitis. It does so by having the therapist apply a force along this common extensor tendon, specifically targeting the extensor carpi radialis brevis. Damaged or inflamed tissues may result in pain localized over the lateral epicondyle when this force is applied. When force is applied, if there's a reproduction of pain localized over this common extensor tendon, this may be indicative of lateral epicondylalgia and would be considered a positive test. A negative test would be no pain or reproduction of symptoms. This test would be indicated if there was a suspected lateral epicondyle musculotendinous pathology based on patient history or symptom presentation. This test would be contraindicated if the patient had a recent hand, wrist, arm, or cervical fracture. Based on a review of literature and Dutton's 2012 third edition orthopedic textbook, no diagnostic accuracy studies have been performed to determine the sensitivity and specificity of Cosen's test. Hi, Lenny. My name is Tiffany. I'm going to be the physical therapist working with you today. Based on what you're telling me, the pain that you're having at your elbow, I think that the muscle that attaches here at your wrist and comes up here and attaches at your elbow might be causing that pain for you, and I'm going to do a little test to see if that's actually the case. What you can expect is I'm just going to be applying a force at your wrist. I would like for you to tell me if you have any reproduction of your symptoms or any pain, and tell me where it is. Okay, so as the therapist, you're going to be standing next to the affected side. The patient is either going to be seated or standing, and I'm going to have the patient go ahead and straighten your arm out here. Great, and so I'm going to be stabilizing at the elbow and also palpating along the common extensor tendon right here up at the lateral epicondyle. And then I'm going to ask the patient, please make a fist. And then I'm going to move you. And so I'm going to move her wrist down into flexion and slight radial deviation, really targeting extensor carpi radialis brevis. And then I'm going to apply a force down into flexion along the direction of my forearm. So I'm going to apply a force at your hand. Don't let me move you. Good. All right. And how did that feel?
I had some pain over here.
Right over the elbow? Okay. And so that's a positive test, which means that you, that might be that muscle that I was telling you about earlier before the test might actually be the source of your pain. It could be a little inflamed, irritated, overused, and we'll explore that some more. Thank you.
Signs and symptoms of this condition include pain over the lateral aspect of the elbow. It is localized to this region and slightly distal to the extensor origin. There is also sharp and exacerbated symptoms with activities involving active wrist extension or passive wrist flexion with elbow extended. There's an inability to hold items due to pain, such as a coffee cup. There's maximal tenderness at the apex of the bony lateral epicondyle, and swelling, erythema, or warmth are rarely present. Pain referral patterns can be found in a study entitled Prevalence of and Referred Pain from Myofascial Trigger Points in the Forearm Muscles in Patients with Lateral Epicondylalgia. Due to active trigger points, pain was found proximally at the lateral epicondyle to the dorsolateral aspect of the forearm and into the wrist. Clinical findings include painful clicking at terminal extension and forearm supination, along with maximal tenderness over the posterior radiocapitellar joints. There is also posterolateral rotary elbow instability, limited shoulder internal rotation. So during a tennis serve, this leads to compensation via excessive wrist flexion, straining the extensor carpi radialis brevis. A positive finding includes all-cause pain over lateral epicondyle by putting the extensor carpi radialis brevis in an eccentric contraction. The Thomas maneuver, chair test, Bowden test, Cozen's test, and Mills test can all be done. Radial nerve entrapment affects 5% of lateral epicondylalgia patients. Nerve trapped within the supinator muscle during resisted supination is what encompasses this. Different treatment options are available. For pharmacotherapy, there are different injections done that are only better for the short term. There's also different agents which stimulate soft tissue healing and or inhibit pain receptors. There's a low-level laser therapy that has greater improvement with pain, and there's weak evidence currently in terms of ultrasound. In terms of manual therapy, some low-level evidence of positive initial effects was found. However, the results were not supported when compared to exercise and injections. Exercise stimulates tendon remodeling and produces muscular adaptive responses. Isometric and isotonic forearm exercises, stretches, and in final stages, functional exercises such as gripping and manipulation tasks are known to be beneficial. Multimodal management is the best. Mobilization with movement, combining concentric, eccentric, and isometric exercise are known to be the best form of treatment. The prognosis. Typical duration of symptoms is between 6 and 24 months. Up to 90% of sufferers report recovery within 1 year. 5 to 10% of patients develop chronic symptoms, which lead to invasive treatment known as surgery. The outcome measures. Common outcomes in the literature include pain gauged by visual analog scale, hand grip strength, and pain-free grip strength. There's also a patient-rated tennis elbow evaluation, which consists of 5 pain and 10 function questions. The total score is out of 100, which includes both the pain and disability scores. Substantial changes in scores are required before they can be considered clinically significant. The clinical significance MCID score is defined as a little better of 7 out of 100, or 22% of baseline score. Also, it is defined as much better or completely recovered, which is 11 out of 100, 37% of baseline score. Here are references for this project.